The dilemma of positive mediastinal lymphadenopathy, N2, disease in bronchogenic carcinoma. Introduction. What is N2 disease? Stage 3 non-small lung cancer, NSCLC, with ipsilateral and/or subcarinal mediastinal lymphatic spread, N2, represents a potentially curable disease. Why N2 is a dilemma? It is a heterogeneous disease. Tumor. Variable size T1 T3. Site. Characteristic, and grade. Nodes. Single station, multiple stations. Single zone or multiple zones. Non-bulky or bulky. Skip lesion or unforeseen. At the diagnostic level. At the decision-making level. Dilemma at the diagnostic level. In spite of negative preoperative results, it was found in stages I and II, that 20% of surgical mediastinal lymphadenopathy have N2 disease. Unforeseen N2 disease. N2 is a heterogeneous disease. Based on T category. T1 T2 N2 is, stage 3A, operate, 10 to 30% 5 years survival rate. While stage 3B, T3 T4, N2, don't operate, 5%, 5 years survival rate. Based on tumor site. Based on the number of stations and zones. If single zonal, PN2A, 34% is the 5 years survival rate. If multizonal, PN2B, 20% is the 5 years survival rate. Based on stations. Station 2 and 4 are 35% 5 years survival rate. Station 7, 22% 5 years survival rate. Station 5 and 6L, 35% 5 years survival rate. Based on timing of N2 disease. Preoperative. Clinical staging. During mediastinoscopy or EBUS N2 disease. 9% 5 years survival rate. Postoperative, surgical staging. During thoracotomy N2 disease. 24% 5 years survival rate. Dilemma at the decision-making level. Needs a decision from multidisciplinary team of thoracic surgeons, oncologist, pulmonologist, pathologist, intervention radiologist. Management. N2 disease harbors occult metastasis. It required local control either by surgery, radiotherapy, multimodality, and systemic control, chemo, immuno, or targeted therapies. Treatment options. Induction therapy, chemo or chemoradiotherapy, plus surgery plus or minus adjuvant chemotherapy. Upfront surgery plus adjuvant chemotherapy. Upfront chemoradiotherapy. When surgery should not be offered. Right pneumonectomy as it carries high mortality and morbidity. And chemoradiotherapy provides similar overall survival. When surgery should be recommended. When the following are all met. 1. A complete resection, R0, of the primary tumor and involved lymph nodes is deemed possible. 2. And 3 lymph nodes are deemed to be not involved by multidisciplinary consensus. 3. Perioperative, 90-day, mortality is expected to be low, less than 5%. Upfront chemoradiotherapy and surgery have the same overall survival. Although clinical trials demonstrated no significant difference in overall survival. Most of these trials did include pneumonectomies, bulky disease, incomplete R0 resections. Didn't incorporate new drugs, targeted and immunotherapy. But showed a significant progression-free survival. Current guidelines and meta-analysis. Left upper lobe 3 cm peripheral mass with positive station 5 and 6 lymph nodes. A practical example. A young male 28 years old bodybuilder discovered accidentally after COVID-19, he was subjected to upfront radical surgery plus adjuvant chemo and immunotherapy. Still alive 3 years 4 months. 78 years old male with grade 3 functional status, previous 2 stents, borderline kidney functions. Upfront chemoradiotherapy, died 8 months later. 74 years old male, fit for surgery. Radical surgery 9 months after adjuvant chemotherapy he developed supraclavicular positive lymphadenopathy, protocol changed to targeted therapy. Died 3 years later for fracture neck femur and pulmonary embolism. 68 years old male, had 3 stents, incidentally discovered, borderline kidney functions, diabetic. Radical surgery plus adjuvant chemotherapy. 2 years and 8 months, his follow-up showed a liver mass proved to be hepatocellular carcinoma. Subjected to radiofrequency ablation. Died from hyponatremia and coma. Conclusion. N2 disease is a heterogeneous disease. Currently, there is no universal agreement about the optimal treatment to incorporate surgery except as a selective option. If surgery is to be encountered, this should be within MDT discussion and dedicated teamwork. The debate will continue. Thank you.